performed to remove the foreign body. During the procedure, an incidental cyst is discovered. The cyst is connected by a fibrous band to the ileum and the umbilicus. The embryological defect underlying the formation of the patient's cyst is also associated by which of the following? So we have a 3-year-old boy. He comes to the ED by his parents after he develops acute abdominal pain and vomiting. Examination shows diffuse tenderness to palpation. There, imaging reveals a foreign body lodged within the intestines, causing SPO. What do you think it is?
Yeah, it's the Meckel's diverticulum.
Meckel's diverticulum. Very easy. What happens in gastroschisis? What's this?
The
anterior abdominal wall defect.
Very good.
And it is not covered by
peritoneum.
Yeah, peritoneum.
And omphalocele is covered by
peritoneum.
Very good. All right. Again, very easy question. You need to be familiar with what Meckel's diverticulum is, what gastroschisis is. Each and everything you should know in this question stem. It's very high yield. Okay. All right. Then we go to the next question. Okay. So researchers studying neural crest migration in a human fetus observed normal activity beginning at the 8th week of embryogenesis with interruption during the 12th week when migration is typically completed. Which of the following structures is most likely to lack innervation as a result of the disruption?
Rectum, because of Hirschsprung's disease, lack of innervation, lack of migration of the neural crest cells. It's to Hirschsprung's disease, so involves the rectum.
Again, very easy. So we know that what happens is that neural crest cells, they enter the developing foregut mesenchyme, and then they kind of migrate caudally along the entire length, and they're present in the wall of the proximal colon by the 8th week of gestation, and they come to the rectum by 12th week. So if you have lack of ganglionic cells, then it kind of results in Hirschsprung disease. Again, the start is very important, so kind of go through it. All right. Again, this is a very easy question. Color Doppler ultrasound imaging shows a normal 3-vessel cord inserting medial to this defect. The remainder of the anatomical survey is unremarkable. Which of the following is most likely cause of these fetal findings? So see, AFP is elevated. I told you guys that AFP is elevated in a number of conditions, and I told you the high yield conditions it was increased in. All right. So anterior abdominal wall defect with herniation of bowel contents adjacent, no covering. Again, very easy. What is this?
Gastric.
Very easy. So, if there was covering, then they might have been talking about omphalocele. AFP is increased in a lot of diseases. We talked about that. It's increased in a lot of, gastroschisis, then omphalocele, in multiple pregnancies, in certain tumors, in liver cancer, and germ cell tumors, it's also increased. So you kind of have to memorize that. All right. Then we go to the next question. Very easy question. I'm skipping it. All right. Okay. So what's happening? The patient had abdominal pain at the time, but they did not seek care until this morning when the pain seemed to worsen. It is suspected that he has an injury involving an organ that is supplied by an artery of the foregut, although the organ is itself is not a foregut derivative. Which of the following is most likely injured? So what do you see in this CAT scan? What's happening?
E. A spleen, that's the E. It's
Alright.
not arise from the
The
foregut,
celiac
but supplied by the foregut branch, splenic artery.
Very good. So the answer is
E.
Again. So we know that this is the pancreas over here. That's the large bowel, liver. These are the kidneys. This is the spleen. Again, in blunt abdominal trauma, 2 organs that are highly injured: spleen, liver. So whenever you do fast, focused assessment, sonography, and so when you do fast, you look for 4 things. What are the 4 things you look for in fast?
But in the fast, we see to look for the bleeding and any bleeding in the abdominal cavity.
Yeah.
Any visceral injury, hematoma formation. So which locations we see?
Yeah. What locations are those?
For all the four locations, the right upper quadrant, left upper quadrant, and the right iliac fossa area, left iliac fossa area, and the umbilical area. We do scan all these things, quadrants especially.
Yeah, very good. So, you check for the cardiac, the pericardium. You also check right upper quadrant, left upper quadrant, and pelvis. So these are the four
Mhm.
things that you look for: pericardium, right upper quadrant, left upper quadrant, because of the liver and the spleen, and pelvis. These four things are highly susceptible to get injured during any blunt abdominal trauma, or in any sort of road traffic accident or RTAs. So you look for these four things in a fast. All right. So again, we know this. It's a kind of like an anatomy question. Very easy root memorization question. I don't think that I have to explain something over here. All right. So slanted palpebral fissures, epicanthal fold, single palmar crease. What are they talking about? What's this?
Down.
Down.
Down
Down
syndrome.
syndrome.
Down.
Very good. Midline abdominal protrusion covered by skin that is more pronounced when he cries. What's this?
Hernia.
Congenital
Oncology.
diaphragmatic hernia.
Hernia.
Was the midline protrusion.
Mm-hmm. There's a midline,
Mm.
which means they're referring to.
That's the congenital diaphragmatic hernia because of the incomplete, incomplete
Complete
closure of
closure of
umbilical ring. Umbilical ring.
umbilical vein. B.
B,
Yeah.
B.
All right. Yeah. So we know that they're talking about congenital umbilical hernia. Again, how do we differentiate congenital umbilical hernia on fallacy gastrocystis? Is by the congenital umbilical hernia. It's kind of benign. It's reducible. Its defect is covered by skin, and plus it's midline. All right, and that's the other thing that you can kind of see this. The in omphalocele, it is covered by peritoneum. It's not covered by skin. In CDH, in CUH, you kind of see it covered by skin, and it's midline and it's reducible. Like all, you have to check for whenever you see hernias, you have to first check if they're reducible or not. Reducible means that the intestinal contents they go in when you press, right? Non-reducible is that they cannot go back in when you compress. All right. So gastrocystis, we know. Again, it's not covered by membrane. It's located to the right of the midline or umbilicus. Again, very easy. I think we've already discussed on fallacy gastrocystis. All right. Next question for today. Abdominal examination shows distension with active bowel sounds. There is no hepatosplenomegaly. DRE results in a forceful expulsion of the gas. What are they talking about? What is this sign?
Hirschsprung.
Squid sign. It's the
Word
squid
sign. Very
sign.
good.
Hirschsprung's disease is seen in Hirschsprung's. And that's
Very
because of cell migration defect.
Mm-hmm. Again, very easy. So you see, you don't have to like go through and read the whole questions. You can just solve it in like 2 seconds or 3 seconds if you're familiar with it. All right. Okay. Exhibit. What does it look like? What's this?
Bilious
Bilious vomitus.
Bilious vomiting.
Bilious vomiting. All right. Very good. So we have a 3-day-old boy, poor feeding, emesis, past for 24 hours. And what's happening is that stool and urine output were normal. The patient is efebrile. He appears dehydrated. The patient vomits during the examination. Fibrous bands. What's this?
It's the
Rotation.
malnutrition.
It's malrotation. It's
Which
labs
gets-
band.
Remember we talked about Latmans when I did a
Latmans.
rapid fire, right? So, okay. So what do you think the answer is?
Mid-gut rotation and intestinal fixation. It's the B. B.
All right. So yeah, it's mid-gut malrotation. We even talked about this. See, these are the LAD bands. I asked you guys this when we were doing a rapid fire as well. So again, very easy. We talked about this concept. I don't think there is anything to go through. All right, intestinal malrotation occurs when the midgut undergoes incomplete counterclockwise rotation. It often presents in the neonatal period with villous emesis. Why? Because of the duodenal compression by the LAD bands, or due to midgut volvulus with intestinal ischemia. So if you kind of go up, you can see that these are the LAD bands that I was talking about, and they kind of compress onto the duodenum, and that is why you have villous vomiting. All right, okay. Next question. Abdominal imaging reveals bowel wall thickening with a blind pouch connected to the ileum. What's this?
Meckel's Meckel's diverticum.
Meckles.
Very good. That's Meckel's. And a laparotomy is performed during the procedure. A fibrous bed is seen attaching to the pouch of the umbilicus. The wall of this pouch it's very easy. We talked about this. Meckel's diverticulum is a true diverticulum. It comprises of,
All the layers,
All three
mucosa,
layers.
submucosa, and muscular layer too.
we talked about this. False diverticulum, Zenker's, true diverticulum is Meckel's. And again, very easy. All right. Okay, next question for today. What's happening in this?
This is
The spleen enlarged,
spleen.
looking like enlarged.
Mm-hmm.
Splenomegaly.
Splenomegaly. What else?
Um, the arrow is over the spleen, and spleen is looking like some enlarged, or what they are asking about.
All right. So what's happened at abdominal CAT scan is show the structure indicated by the arrow originates from the same embryological germ cell layer at which of the following tissues. They're referring to the spleen, and it what? What is the answer? Which of the following tissues
Spleen
have
arise from
The muscle.
mesodermal regions,
Skeletal
or
muscle.
liver,
Mesodermal. Both are
skeletal
mesodermal.
muscles have,
Skeletal muscles.
yeah, skeletal muscles have also mesodermal innervation.
again mesoderm, which means middle?
Mm.
Remember, muscles are in the middle of the skin and the bones. So yeah, okay. So skin and bone between muscle, mesodermal, middle muscle. All right. Again, these are not that high yield. They don't really ask this on USMLE step one. They can give you one question max from this, and at that time nothing gets remembered. So you kind of just teeny, meeny, miny, mo in between the answers. It's not worth remembering each and everything, but just remember, the important things. For example, for ectoderm, it's anterior pituitary. That's very high yield for you to remember. Then remember the epidermis, sweat, and mammary glands are very high yield. Cornea, lens, in the neural tube, all of it is really high yield. In the neural crest, adrenal medulla, they ask Schwann cells via arachnoid matter, and they ask melanocytes. The rest they don't ask. Okay, the mesoderm, they ask muscles. Muscles is important. Connective tissue is really important. And another thing they ask is adrenal cortex, and sometimes kidney and spleen. So this is important. Endoderm, they ask about bladder and urethra, thymus, and the GI tract. So just remember the high yield stuff. You don't have to memorize each and everything. It's not that important. If you want, you can skip it as well. All right, next question. So amniocentesis shows a fetal karyotype of 47XX plus 21. What's this?
Downs.
Down,
Down
Down
syndrome.
syndrome.
Down syndrome. AFP is reduced, all right? You have increased nucleotranslucency, so they're talking about that there's some Down syndrome. Down syndrome is associated with what? The fetus is at a greatest risk of developing what?
Esophageal
Herniation.
Duodenal
atresia.
atresia. It's
Recanalization.
associated with duodenal atresia, failure of recanalization within intestines, and also the congenital diaphragmatic hernia, but it's not the herniation of the bowel due to failed abdominal wall development. It's not the congenital diaphragmatic hernia. So that's why.
All right. Okay. What do you mean by C? What's C?
Yeah. C is the abdominal wall development. So it could be the gastroschisis. Gastroschisis, yes.
Gastroschisis. All right.
Mhm.
Okay. So, these are very high yield, important findings that you have to, kind of memorize with Down syndrome, Down syndrome associations such as cardiac AV, septal defects, VST, AST, GI, osteoarthritis, Hirschsprung.
Mhm.
Then, acute leukemia you get, and then epanoaxial, All of these are very high yield for you to remember. The associations are very high yield. And okay, next question. Coagulation studies are normal sequential imaging using pectinate scintigraphy demonstrates focal radiotracer accumulation in the right lower quadrant, which is the following embryological process likely result. Where do you use pectinate scintigraphy?
Also, the Meckel's diverticulum,
Metal.
because it's the
Vertical.
technetium scan that's diagnostic for the Meckel's diverticulum, and it's because of failed obliteration of vitreous duct.
Failed obliteration of the
Mec-
vitelline duct. Again, very easy. Okay, it's a very easy question. Again, you get diverticulitis. It can mimic appendicitis as well. The rule of twos is very ideal. Remember that there's ectopic gastric and pancreatic mucosa both. And yeah, okay. You also have painless rectal bleeding. So it can be associated with IDA, iron deficiency anemia. All right. When the infant attempts to breastfeed, however, several bouts of coughing and perioral cyanosis develop with the oxygen saturation of 85%. Which of the following is most likely cause of the patient's conditions? We have a 6-year-old boy in the newborn nursery with feeding difficulties. The patient was born at 39 weeks gestation to a 33-year-old prima gavida via C-section due to failure of progress and late decelerations. All right, excessive drooling and coughing. The everything else is normal. What's happening?
Brachioesophageal fistula.
fistula.
Brachioesophageal fistula.
Fistula, and that is
Fistula,
because
yes,
of failure of
cancers.
primitive foregut to separate from airway. Because the premature
Yes,
baby and there is
esophageal
early feeding
atresia.
problem and drooling and coughing also the hint here.
So what do you think the answer
C.
is?
C.
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 C. Yeah. So again, it's CF or esophageal atresia and tracheoesophageal fistula. Uh, Again, we know that the baby will have mother's condition will have polyhydramnios because the fetal will not be able to kind of swallow the amniotic fluid, and as a result, the patient will have choking, coughing, and cyanosis with C. Again, X-ray will show us a stomach bubble. And this is not high yield, but just remember what's TEF. I think we talked about this yesterday as well. And yeah, okay. And then we come to the next question. The proximal jejunum ends in a blind pouch. The distal jejunum and proximal ileum are absent. Distal ileum is present in wide around a thin vascular stalk. What's happened? What's this condition called?
Intestinal atresia.
Duodenal
And
atresia.
Canalization failure.
Jejunal ileoatresia.
jejunal area.
Mm-hmm.
And it's because of vascular occlusion. It's the duodenal atresia is because of recanalization defect, and the jejunal or ileal atresia is because of vascular occlusions.
Yeah,
Ischemia.
of the mesenteric SMA.
E. Yeah.
All right. So what do you think the answer is?
E. Vascular occlusions.
Vascular occlusion. All right. Yeah. So again, we know that we discussed this yesterday as well. Duodenal, jejunal. Again, duodenal atresia is because of the recanalization failure. Jejunal is because of the vascular occlusion. Again, you will have dilated tubes of small bowel with air fluid levels absent, distal gas. You will also see this thing called triple bubble sign in the jejunal atresia. And again, you can have a lot of other intestinal pathology with jejunal atresia, such as gastrocystis, volvulus. Again, uh, very, very easy. I always find GI very easy. Is that the case for you guys as well, or do you find it difficult? Do you find it difficult? Do you find GI
Easy.
difficult? It's easy, right?
Yes, difficult.
It's difficult. Why? I find it the easiest.
Things are very confusing,
Things are
intertwined.
very confusing. I mean, they're very typical. I mean, they're very like pathology oriented. In neurology, it is pathology oriented, but it takes a lot of time to figure out what's happening because most of the neurological conditions are looking the same. right?
Yeah.
So I find neurology personally very difficult, and I find GI the easiest. I mean, it can be a different case for you, but that's at least what I find on a personal level. All right, chest X-ray reveals multiple fluid containing cystic areas to the left and a medial sinus shift to the right. Which of the following embryological events most likely fails to occur in this patient? So we have a newborn boy in the NICU, and the Apgar scores were 2 and 5. The risk patients were 84. On examination, the patient has a barrel chest with a scaphoid abdomen. Talking about congenital diaphragmatic hernia. All right. What's that? Why does it occur?
No, it's the closure
Okay,
of
closure.
perineal fold,
Closure of
not
the
the
closure.
pleuroperitoneal. A,
Right. Yeah.
because the congenital diaphragmatic hernia is because of pleuroperitoneal membrane defect. Yeah.
Exactly. This is scaphoid abdomen barrel chest, very ideal findings for CDH. Again, absent, breath sounds on the left. That's something highly concerning. Chest X-ray reveals multiple fluid containing, again, cystic lesions. That's CDH. So, it's because of the closure, absence of the closure of pleuroperitoneal folds. That is why the intestines kind of bowel loops into the left lung. All right. Okay. Where do we? Okay. Okay. Yeah. So we discussed this. Next question. What's this?
Celiac disease, blunting of the villus.
Yes.
Hmm? So we have a 18-year-old man comes with evaluation of fatigue. He does not use alcohol or recreational drugs, but smokes a pack of cigarettes. He has conjunctival pallor. HP is low. So I told you guys that the easiest way to differentiate between any other malabsorptive diseases is that if it's something pathology oriented in terms of intestines, you will have collective malabsorption. So you will have iron deficiency, anemia, vitamin D levels will be low. You know, and again, so the pouch is surgically resected and the microscopic findings are shown below. The patient's condition is most likely the result of which of the following pathological process?
It's
What's
the Mackles. It's the Mackles diverticulum. Because of its location, first thing its location, they have told us in the site of hemorrhage is 5 centimeter outpouching of the intestine, and it is the hemorrhage is within the ileum, just proximal to the site of hemorrhage is 5 centimeter outpouching.
mm-hmm,
Um, so it's the according to the location, this kind ending pouch will be the Mackles diverticulum.
mm-hmm,
It is resected and microscopically we can see the in macroscopic on microscopic appearance we can see the ectopic gastric mucosa as well as the pancreatic pancreatic mucosa. So here is the gastric mucosa we see in this histological.
mm-hmm.
So the answer will be the ectopic because it's the ectopic mucosa, gastric mucosa here in the Mackles.
All right. Okay. So let us go down and see. So the answer is
Ectopia.
Yeah, it's
Ectopia.
not the anaplasia, not the dysplasia.
so again, it was an intestinal outcrouching and showed gastric mucosa. Again, we talked about that those patients kind of also have bleeding present in the stool as well. They said 5 centimeter outcrouching. That's a clear indication of Meckel's diverticulum. Again, it's most likely removed. I told you guys yesterday that Meckel's diverticulum, they can occur within the child as well, and it can also be found in an adult as well. All right. Okay. So then we go down. Abdominal imaging is shown in the exhibit. What's wrong? What's
The
what's wrong?
the gastric is distant
Variant
and
study.
yes,
Very
duodenal
here we can see
access
the
point.
stomach is opacified as well as the first part of duodenum is opacified in the first image. In the second image, we can see the in this follow through the barium is going down and involving the also opacifying the second part of and second and the third part of duodenum, just the a part of third. And then in the end, it's the small intestine is getting opacified, but that's on the
Mhm.
only the only the small gut is gets opacified. So here they are asking needed to abdominal imaging is shown, surgical intervention is needed
Superior mesenteric
to
artery.
prevent the ischemia of these structures.
E is it
Supply
is
the artery. Yeah, it is because of the volvulus and the superior mesenteric artery gets whirled around the mesentery that leads to the volvulus formation. So here we have to uh, we can remove the superior mesenteric artery. Surgical intervention is needed to prevent the ischemia. E. E will be the answer.
So E will be the answer. Okay.
Yeah.
Let us see. All right. Yeah. Again, so they were talking about the malrotation. If you see
Math.
contrast in the stomach in
Mhm.
the first part of the duodenum, and then you kind of see it over here, and then kind of see that the gut is malrotated over here. So they're referring to a midgut malrotation. Incomplete rotation causes midgut malrotation. Again, there are two important pathological points, but you don't have to memorize that. Just remember that the mobility permits twisting around the SMA or the superior mesenteric artery or the midgut volvulus. And when kind of SMA gets compromised, and the SMA supplies to a lot of structure, such as distal duodenum and proximal transverse colon. And if it kind of gets compressed, there's obstruction of blood flow, and there will be ischemia of these two places. And that is why it is high yield for you to remember that we take the patient into surgery to kind of reduce or to restore the blood flow in SMA. Otherwise, your gut will get compromised. All
Uh,
right.
excuse,
Yeah. Do you have a question? All right. Okay. So the patient has been exclusively breastfed since birth. His last bowel movement occurred this morning. Okay. Blood pressure and pulse are normal. Physical examination shows abdominal distension. Vomit sample is consistent with villus, emesis. All right. So what's happening? 4-month-old boy evaluated in the ED due to persistent vomiting. The emesis is initially clear, but became villus over the last few hours. 39 weeks gestation. What's happening?
Midgut malrotation.
I think it's something with the pancreas.
Bilious,
Pancreas,
if the
annular pancreas. I
if
think
the
it's annular
bilious
pancreas, maybe.
if the bilious masses, we should come to in mind that it must be some duodenal atresia distal to the ampulla of the water. So that could be because of duodenal atresia could be itself or because of some annular pancreas that can also cause the duodenal atresia. And in that case, we see the bilious vomiting. So here in the options, we have the abnormal rotation of ventral pancreatic bud that is
Yes, should
annular
be the answer.
pancreas that cause the duodenal atresia. And because of that, there will be the bilious vomiting. So A will be the answer here. If it could be the pyloric stenosis or the hypertrophy in HPS, it will not present with the bilious. It will be the non-bilious. And the other options are also not in the favor.
Hmm. So what do you think the answer is?
A.
A.
A, abnormal rotation of the ventral pancreatic duct. Again, it means that there was some annular pancreas development. And then what happens is that because the patient had abdominal distension and bilious emesis, they were suggestive of any sort of intestinal obstruction. And the only defect that could cause obstruction beyond the site is the annular pancreas. It's a rare congenital anomaly that develops in utero. Um, okay, what is the treatment of annular pancreas? How do you treat it?
Surgically, we treat it surgically
So what do you do?
because it is basically the abnormally it is encircling the duodenum, and we should remove that part of the pancreas
Mhm.
or remove the encircling.
So there's this thing you call a duodenal bypass. You do a duodenal bypass in this. It's kind of like the main treatment for annular pancreas, and that's what you do in annular pancreas. All right. Okay. Next question. Upright chest X-ray shows an opacity with an air fluid level behind the heart. All right. A subsequent variant solo reveals the proximal stomach herniating through the esophageal itis. We talked about it, or we talked about hernias previously. Which of the following pathophysiological changes most likely contribute to the patient's current condition? So what's happening? Obese patient, heartburn, regurgitation, dysphagia. What's all of this? What are they talking
Hiatal
about?
hernia?
Hiatal hernia. Very good. Why do they occur?
Hiatal hernia is because of laxity, uh, phrenoesophageal membrane laxity.
Yeah. So we talked about hiatal hernia, and we also talked about that there are two types of hernias, sliding and paraesophageal. So in this, you kind of see the herniated gastric cardia, but over here, you see there's some sort of membrane defect, and you see a herniated gastric fundus. So it's different. Again, we talked about this, so I'm not going to go over it again. All right, second last question. In anticipation of a large for gestational age baby, a decision is made to transect the rectus abdominis muscle. If the rectus abdominis muscle is incised laterally, which of the following structures is at greatest risk of injury? Come on, guys. Very anatomy related question.
Inferior epigastric artery.
Superior
Yes.
epigastric artery.
Epigastric.
Inferior epigastric artery.
No, inferior epigastric artery. Yes, inferior epigastric. D.
Inferior, because the inferior epigastric artery is crossing vertically over the rectus
Rectus
abdominis.
abdominis.
If we transect it horizontally, so it will be dissected. Inferior epigastric.
Mhm.
D.
So it's inferior epigastric. All right. Okay. Yeah. So again, very anatomy related question. You have to remember, kind of go through this. Not very high yield. But yeah. Okay. Last question for today is this. On examination, she has ecchymosis over the area of the seatbelt and abdominal tenderness. CT scan of the abdomen reveals a retroperitoneal hematoma. Which of the following injuries is most likely to be responsible for the patient's internal bleeding? So we have a woman, and she was brought to the ED for an end-to-end motor vehicle collision. She was a restrained passenger and did not hit her head or lose consciousness. She has had abdominal pain and nausea since the collision. Blood pressure is this, pulse is this. What's happening?
It's injury to the pancreas.
Yes. Yes, because the retroperitoneal organ is the pancreas over here in all the options.
All right, okay.
A.
A.
Yep.
Okay, very easy. Again, retroperitoneal organs, abdominal organs, we know the kidneys, retroperitoneal, suprarenal adrenal glands, duodenum, except the first part, ascending colon, uterus, rectum, mid to distal, aorta, IVC, descending colon, pancreas, head and body, esophagus, all of them are retroperitoneal abdominal organs. We know that when they're talking about that, only thing that's retroperitoneal over here is the pancreas. So yeah, so we're done with today, guys. All right, if you have any more questions, you guys can ask me, and then Dr. Ahmad will be taking the class. Yeah, no question. No.
No questions. Thank you.
Thank you so much, Doctor.
Okay, yeah, Dr. Ahmed, are you here?
Yes, I'm here. So let's have 5 minutes of break and then I'll be starting my session, okay?
Okay, bye, guys. I'll see you tomorrow.
Thank you so much, Dr. Maheen.